Hi, everyone. Thank you for joining us for the webinar, Optimize Outcomes, Managing Avoidable LUPAs under PDGM. Today's webinar is being presented by McBee, the nation's leading healthcare services and consulting firm. We deliver clinical, financial, and operational services exclusively to healthcare providers across the continuum of care. First, I would like to cover a few housekeeping items. Today's webinar is being recorded. We will be able to share a link with you after the event is complete. We welcome you to revisit the content yourself as well as share it with your colleagues. We invite your comments and questions. If you have any questions during the presentation, please type them into the question box in your Zoom control panel. Following the webinar, as time permits, we'll answer as many questions as we can. We'll also be in touch via email to provide you a copy of the recording and of the PowerPoint presentation that we are presenting today. Today's presenters are Carissa McKenna and Catherine Bella. Carissa is a senior clinical consulting manager at McBee with more than 21 years of experience in the healthcare industry. While working with providers, Carissa has developed and implemented several clinical workflows, as well as documentation and quality assurance tools. Catherine Bella is a clinical consulting manager at McBee. Catherine has 25 years of experience in the healthcare industry, with 17 years in home health and hospice. Catherine currently manages several episode management engagements, helping organizations to improve their adherence to the established plan of care to ensure positive outcomes clinically, financially, and operationally. So thank you all for joining us for today's webinar. I'm gonna hand it over to Carissa to get started.
Thank you, Ashley. Thanks, everybody. We're obviously here to talk about optimizing outcomes by managing your avoidable LUPA under PDGM. Our primary focus is going to be on those subsequent 30-day periods. So our objectives for this session are to identify common trends in subsequent 30-day period LUPA. We're going to look at some data, some information. We're going to establish ways for you to maximize use of your electronic medical record, or your EMR, to help you manage the subsequent period LUPA. And we're going to describe some best practice strategies that you can put into place to help you manage those and mitigate those subsequent period LUPA. So before we get into what you can do to mitigate those avoidable subsequent period LUPA, we want to talk a little bit about why your focus should be on those subsequent period LUPA in the first place. On the next few slides, we're going to share with you some data and statistics that are based on McBee's market reporting analysis of Medicare's Q1 and Q2 2020 PDGM claims data. So first, we're going to talk about subsequent period visit utilization. The data shows us that almost 70% of subsequent period LUPA had only one visit made in the entire subsequent 30-day period. Why is that statistically significant? First, one visit in a period is always going to be a LUPA. Second, we know that the majority of subsequent periods have a really low LUPA threshold of only 2 or 3. So that's pretty significant. And as you can see on this next slide, almost 85% of the subsequent period LUPAs are only one visit short of meeting that LUPA threshold, meaning one more visit made within that period would have resulted in a full period payment rather than a LUPA payment in 85% of those instances. When we analyzed the data, we found that the most common clinical groupings to result in a LUPA in that subsequent 30-day period were complex, which makes sense because these are your catheter patients, your ostomy patients, MMTA surgical, which is your aftercare following surgery patients, and MMTA infectious disease. These are your patients that are on service with post-surgical infections, immune system diseases, cancer. Those subsequent two categories, MMTA surgical and MMTA infectious disease, really we wouldn't expect those to be at a higher LUPA risk. We would expect these to be high-risk patients that require additional visits into the subsequent period. So we really would want to be focusing in on those patients to find out what's going on that is creating LUPA in those subsequent periods for those patients. When it comes to comorbidity adjustment, yep, you guessed it. The subsequent period LUPA patients most often had high comorbidity adjustments. And the data also showed us that subsequent period LUPA patients also most commonly had high functional impairment levels. So putting it all together, what does it all mean? Subsequent 30-day period LUPAs are most commonly made up of more complex, high-risk patients with high comorbidity adjustments and high functional impairment levels. We're often only providing one visit to the patients who have subsequent period LUPAs, and we're missing the LUPA threshold by only one visit in the vast majority of cases. So this is kind of the importance of the data when we're honing in on those subsequent 30-day period LUPA. Now let's talk a little bit about how you can maximize use of your EMR to help you mitigate those avoidable LUPA in the subsequent period. So optimizing episode management and EMR utilization is key to successful mitigation of those avoidable LUPA. Key number one, episode management key number one, is to know the period start and end dates for each of the two 30-day billing periods in that episode of care. Now remember, there's only one 60-day certification episode. It's just now split into two 30-day billing segments. So there's still only one 60-day plan of care. One of the most common issues that we're seeing right now is overutilization in the first 30 days, a lot of visits in those first 30 days, followed by underutilization in the subsequent 30-day period. Clinicians are often not scheduling out through the entire 60 days, result in poor tracking of the payment periods, the billing periods. It's really critical to know when one 30-day period ends and the next one begins, because simply moving a visit from one day to the next day under PDGM can mean moving a visit from the first 30-day payment period to the subsequent 30-day payment period. And that could just be the discharge visit, which means you've got a one visit LUPA for discharge. So where do you find this information in your EMR? There are a lot of different areas that you should be able to locate this data. First, the patient calendar, the scheduling or scheduler's calendar, it should be there. Sometimes in some EMRs where you enter your visit frequency, that information gives you the start and end dates of each of the 30-day periods. And there are also sometimes other areas within your EMR. So you really need to know in your EMR, where is this data located? The other thing you can do is calculate it yourself. Add 30 days to the start of episode date, and that will give you the end of the first 30 days and the beginning of the next 30 days. Okay, so those are some things that you can do, but it's really important that you know the start and end dates of each of those 30-day billing periods. So key number two, know your LUPA threshold. What is a LUPA threshold? Well, a LUPA threshold is the number of visits that need to be met. The number of visits need to be made in order to qualify for a full 30-day period payment. Under PDGM, those thresholds range from 2 to 6, and it depends on the HIPS, Health Insurance Prospective Payment System code. Each 30-day billing period has its own LUPA threshold. So the first 30-day threshold is going to be different than the second 30-day threshold. They aren't going to be equal. And now where do you find that information in your EMR? Again, this is going to be highly variable. If you do not know where to find it in your EMR right now, you should reach out to one of the super users within your agency or to your EMR vendor for clarification. Another way for you to find out without going through your EMR is to look up the patient's HIPS code, Health Insurance Prospective Payment System code, as I had mentioned before, in the CMS PDGM case mix weights and LUPA thresholds file that's on the CMS website. I've included the link here. And so you look up the HIPS code and it will tell you what the threshold is for that 30-day period. Now, HIPS codes are going to be different for each of the 30-day periods. That's why your LUPA thresholds are different for each of your 30-day periods. Key number 3, knowing the clinical grouping and the primary focus of care. Why? Because this identifies the primary reason for home health services. It helps us to figure out which discipline or disciplines are most critical at the initiation of the episode. It helps us to identify the frequency of visits needed, determine the focus of the plan of care. Where would you find this information? Well, it should be found in your referral information from your referring provider, your face-to-face documentation, on your plan of care or your 45, and in the narrative for your start, resumption, recertification. All of those different pieces should substantiate one another. So referral, face-to-face, plan of care, recert, or start of care narrative, they should all substantiate one another. We shouldn't be seeing something different in the referral information versus the face-to-face versus the start of care narrative. We really should be seeing similar information in all three. Now, if we're seeing something different, if the face-to-face doesn't match what the start of care narrative says we are focusing on, then we need to reach out to the doctor, because we may need to get a different face-to-face. The patient may need to see the doctor again because we've identified that there's a different focus of care. Key number 4, knowing the functional level. The functional level tells us how functionally impaired the patient is. It helps us predict what kind of therapy or additional resource involvement might be needed to manage that patient's care and to optimize their outcomes. So a high functional level means that there is a lot of functional impairment. That patient needs a lot of help, and they may need additional care within that period. So they may need a higher frequency of visits, additional disciplines involved, so on and so forth. This information is found by looking at the patient's HIPS code. Position number 3 is the functional level. And I'm going to show you here on this slide, you can see the different factors that play into the HIPS code positions. 1, 2, 3. As you can see, position number 3, functional level. It's going to be either A, B, or C, low, medium, or high. Those are the only 3 options for functional level. Okay, so low, medium, or high. Low meaning the patient doesn't need a lot of assistance. Medium being there's a moderate level of functional impairment going on, and high being this patient really needs a lot of assistance to safely perform their activities. Episode management key number 5, knowledge of the disciplines that have been referred or that are already involved in the patient's care. This tells us who we expect to be involved in the care plan. It helps us to improve coordination across the care team. It prevents overwhelming the patient with too many visits on one day or even within 1 week. This information can be found in a few different places as well. The referral information first should tell us which disciplines were ordered by the referring provider. The start, resumption, or recert narrative should indicate any discussion that was had with the patient about additional disciplines that were recommended that we've identified that this patient really would benefit from, and any refusals that the patient might have said, I don't want to have physical therapy right now. I just had them 2 months ago, and I'm still performing this exercise program. So it should tell us that in that narrative. The plan of care needs to include orders for all the disciplines involved or ordered. And interim orders would list the additional disciplines that were ordered between the time of that initial plan of care going to the doctor and a subsequent visit. So the initial plan of care is created, and then later on the patient has some kind of a change in status, and we have reached out to the doctor to get orders for another discipline. That's going to go in an interim order, and that's where we should find that. Key number 6, patient goals. Patient goals are probably the most critical element to mitigating avoidable LUPA under PDGM. They are what helps us engage the patient in their care. They give us patient buy-in. The patient actually cares about the plan of care for home health because we are working on something that's important to them. They help us to frame the plan of care by helping us identify what interventions are needed in order to successfully meet the patient goals, identify barriers that the patient's facing with regard to their ability to meet that goal, and it gives us insight into additional resources that might be needed in order to meet their goals. So that could be additional home health disciplines, or maybe community resources, or referrals to specialists like psychiatric services, urology, neurology, so on and so forth. After we identify patient goals, interventions, and barriers, we're usually able to better estimate the time frame realistically needed to meet those goals. And that helps us have a better understanding of how long home health services might be needed to be involved with the patient. So where is this information found in your EMR? Patient goals need to be clearly documented on the Plan of Care 45. Additionally, you should have a specific area within your EMR that is clearly identified for documenting specific patient stated goals. So specifically, what did the patient say their goal was? There needs to be a designated spot in your EMR for that. All clinicians should be educated in where that is and on the process for adding and revising the goals in that area. So key number 7, we're going to talk about missed visits. This is everybody's favorite, isn't it? Missed visits. It's imperative that we are aware of missed visits and that we reschedule any missed visits that occur. I had mentioned this earlier, but visit schedules are built on patient need and Plan of Care goals. So all ordered visits on the Plan of Care are anticipated to be necessary to meet the patient goals of care. So it's really not okay to have a missed visit because we determined at the beginning that we needed that visit in order to meet the goals. That's why we built the visits into the Plan of Care. It's essential that we prevent gaps in care. We ensure best practice front-loading guidelines are being met. We want to try to do service recovery attempts if the patient has multiple missed visits in a row so that we can get the patient back on track with their Plan of Care to help improve their outcomes, meet their goals. Missed visits that aren't rescheduled, they can lead to spillover into the subsequent 30-day period, sometimes resulting in a LUPA for the first period, sometimes resulting in a LUPA for the second period, sometimes resulting in a LUPA for both 30-day periods. Okay, and oftentimes it can lead to poor clinical outcomes and decreased patient satisfaction because of those gaps in care, and we're not meeting the goals, and we're not where we need to be in order to achieve our outcomes. So where do you find missed visits information in your EMR? The calendars, right? The patient or the scheduling calendar. Also, most EMRs, I can yet to think of one that doesn't have this, have a type of missed visits report that can and should be run on a regular basis. You should be having someone that is directly responsible for the missed visits report and running that on a regular basis and following up on patients that have multiple missed visits and so on and so forth. If you are not sure where to find that in your EMR, again, super users within the agency, reach out to them. If no super users, reach out to your EMR vendor so they can help you figure out how to run that missed visits report. But that is definitely something that you want to be running on a regular basis. Key number 8 is patient tracking. Now, urgent emergent care visits and hospitalizations, they are not ideal. Of course, we strive to avoid these, but they do still occur sometimes. If they occur, it is imperative that you have a well-organized patient tracking process in place. It helps us to mitigate any gaps in care created by poorly tracked urgent or emergent care visits or observation stays. So the patient goes to the hospital, but they're not admitted. They're in there urgently and then they're sent home. We didn't really do a good job tracking and we didn't see the patient for 5 more days. That's a problem, because this patient went to an urgent or emergent care for a reason. We should have followed up more timely on that, okay? So things like that. Also helps us to ensure a timely resumption of care after an acute care hospitalization or other inpatient stay. So most EMRs have some sort of a hospitalization report for tracking patients after a transfer oasis has been completed. Our best practice recommendation is that agencies develop a process for at minimum weekly tracking of patients who have been transferred or are being held under observation or in urgent care, with clear documentation of patient status, meaning the patient remaining inpatient at such and such a facility, or the patient is transferred here, or expected date of discharge and such. We want to prevent this patient from being what we would call lost to follow up, or we have lost track of where the patient is, and so they're no longer at that originating facility, but we don't know where they've gone, and we aren't able to obtain that information. We also want to prevent them from being picked up by another agency. If they're on service with us, we want them to come back to us and continue with their plan of care. So now that we've gone through our data, our statistics, and some keys to maximizing EMR use for episode management, I'm going to go ahead and hand this presentation over to Kathy to talk you through some best practice strategies for mitigating those avoidable LUPA.
Thanks, Carissa. So here we are, best practice strategies for managing subsequent 30-day period LUPA. Oops, sorry. Okay, as we look at building a plan of care that will bridge the billing periods, we need to remember a couple of things. As Carissa said earlier, under PDGM, we still have one 60-day episode and one 60-day plan of care, with that 60-day episode being broken down into two 30-day billing periods. Knowing the start and end of those billing periods are really key. Each 30-day billing period, as Carissa said earlier, will have its own HIPS code and its own LUPA threshold. The LUPA thresholds vary between 2 and 6 visits. Typically, you'll see that larger number on early episodes and the smaller number, as Carissa said, 2 to 3 visits in the subsequent billing periods. Clinicians need to consider the following. What is the primary focus of care? That primary focus of care will be the first code on the 485, and that will determine what clinical grouping the patient is in. Then another thing to consider is functional impairment level. What is their patient's stated goal? What do they want to accomplish with home care? What disciplines are involved in the plan of care? Do we have any missed visits not scheduled within the Medicare week? We need to be very attentive to that. As Carissa emphasized earlier, all of the visits that were planned are necessary. So we need to keep with the plan of care. If the patient has been admitted to a facility, we need to keep up on that, where that patient is, where they're currently located. Have they been transferred to another facility? And we need to document that in the medical record so that everybody knows. Okay, next slide. When constructing a plan of care for physician approval, it's important to look at that entire 60-day episode and consider the clinical picture of the patient as well as their functional impairment levels. When multiple disciplines are involved in caring for a patient, interdisciplinary collaboration is critically important. I cannot emphasize that enough. We have 60 days to provide care to our patients. We don't want to overwhelm them in that first 30 days of care. Spread out the visits. Consider either tapering out or tapering up each discipline's frequency depending on the individual needs of the patient. The interdisciplinary plan ideally should address the most pressing issues at the outset, that primary focus of care, and then address skills needed for long-term self-maintenance. For example, if a patient is coming to us from a hospital, right? A lot of us get referrals from the hospital. That first 30 days should really be focused on keeping that patient out of the hospital and monitoring and assisting in their recovery, while the subsequent 30 days can focus on long-term self-management skills that the patient needs to keep their disease process under control and avoid exacerbations. It's also important to consider that patients, we have some patients that are on service for long-term care. For example, that 30-day, that long-term patient who's on service for catheter changes monthly. Don't forget, we need to keep a focus on holistic plans of care. We want to emphasize that with the clinician. So we're not just seeing the patients monthly. Perhaps adding weekly check-in calls to check on patients and see how they're doing. during the weeks that the patient is not scheduled to be seen. This way, we can keep on monitoring any changes that are occurring, doctor's visits, urgent care visits, change in caregivers, skin changes, hospitalizations. These are just a couple of things that we can keep track of with these check-in calls when we're not scheduled to see the patient. The referral for home care services will include discipline or disciplines ordered by the provider. The start of care clinician is obliged to complete a comprehensive assessment of the patient. Is the functional assessment of the patient, is the functional level or functional impairment of the patient consistent with what came on the initial order? Has the comprehensive assessment uncovered any additional needs for a holistic plan of care? As a condition of participation, a patient's stated goal is required to be identified through a collaboration between the patient and the clinician. And again, Carissa mentioned the importance of that patient's stated goal driving and keeping that patient engaged in care. For example, if a patient wants to do their laundry again, what would be involved in getting the patient to the point where they can actually do their own laundry? Is a nurse needed to educate about medication or disease processes that may cause dizziness for the patient? Are they at risk for falling based on a standardized scale? Do they have the necessary balance to carry a laundry basket safely to the washer? What kind of washer and dryer do they have? Where's that located in their home? Do they have the upper body strength to carry a laundry basket? And do they have the fine motor skills to fold or hang the finished laundry? When planning the number of visits and the duration of a discipline's care plan, what should be addressed most urgently and at a higher frequency and taper down so that another discipline can taper up? So front loading that urgent need first and then add the other needs. As one tapers up, another can taper down. So what do we do when things don't go as planned? We have a plan for that. It's important for patient care that we stick to that plan that was approved by the provider. So is there anything we can do about the issues of missed visits? Most, if not all, EMRs, as Carissa mentioned, have some type of missed visit reporting capabilities, whether that be a missed visit report, a patient not seen in X number of days report. There's something in there. Managers and supervisors can use these types of reports to look for trends with patients and clinicians. If a certain clinician is identified as having more missed visits than other clinicians, a one-on-one session with the clinician is in order to determine the issue and educate them on ways that they might mitigate their missed visits. If a pattern is seen with a patient, this is an opportunity for service recovery. The manager or supervisor can reach out to the patient themselves and attempt to find out the reason for the non-adherence to the plan of care and see if anything can be done about that. Managers and supervisors should educate the clinicians to front load visits on a new start of care, ensuring those disciplines ordered on the referral get in to see that patient within that 5-day start of care window. Secondly, visits that are missed should be rescheduled as soon as possible within that same Medicare week. Remember that those visits were deemed to be necessary, so we really need to get them in, ideally within 24 to 48 hours. Finally, use telehealth if you have it. Use telemonitoring visits. Use phone call visits. Phone visits and telehealth visits are great for increasing patient touch points, but remember, they don't replace in-home visits. There are times when it is necessary for patients to be admitted for inpatient care. How is your organization tracking these patients? As Carissa mentioned earlier, an organization needs to have a well-defined way of tracking and documenting patients that are in the hospital. Best practice is to follow up on the patient and document the situation in the patient's medical record on at least a weekly basis. With the ongoing public health emergency, it's true that many hospitals restrict who can enter their facilities. Agencies can follow up with hospital case management by phone. Agencies can also use the patient's emergency contacts to keep in touch with family members and loved ones, to let them know that, yes, we're interested in their loved one. Yes, we want to know what's going on. And oftentimes, emergency contacts and loved ones know about discharge plans long before case managers are sharing that. And it's also a way to keep a patient from being lost to follow up and emphasizing that patient choice idea with their families and letting them know if they're happy with their care, they can certainly come back to our agency, even though the facility might be offering another agency. Patient touch points and interdisciplinary communication are vital when we know that the patient has access to ED or urgent care. If the agency is aware, a visit should be scheduled within 24 hours to assess the patient, to see what's going on, what brought them to the ED, what happened that required them to go to urgent care, and see if there are any modifications to the plan of care. If the patient is admitted to inpatient care and is then discharged with orders to resume home care, every effort should be made to see that patient in less than 48 hours. Similar to the start of care, the resumption of care should include a comprehensive assessment to discover the current condition of the patient and the needs of the patient. This is a fresh look at the patient, and that's really important to know and emphasize with the clinicians, that this isn't just resuming whatever we had going on at start of care. It's a fresh look at the patient to determine their needs. Consideration to front loading and additional discipline evaluation should be addressed based on the comprehensive assessment findings. In summary, 70% of subsequent 30-day billing periods that ended as a LUPA have only one visit made in that period. A startling 85% of subsequent 30-day billing period LUPAs have missed the threshold by only one visit. Managers and supervisors absolutely need to ensure appropriate utilization throughout the 60-day period, appropriate discipline involvement, adherence to best practice standards of care, and most importantly, all clinicians need to take a holistic view of their patients, including those long-term patients, and continually carry out interdisciplinary communication. Interdisciplinary communication on a regular basis is vital. Agencies need to have a well-defined process for tracking missed visits, emergent care, and patients that have been admitted to inpatient care. Using the best practice strategies discussed here today and optimal use of your EMR, which, everybody's got a different EMR and different EMRs are better at assisting or whatnot, but knowing your EMR and what it can do for you is really important in mitigating avoidable LUPAs occurring in those subsequent 30-day billing periods of that 60-day episode of patient care. Thank you.
Great.
All right. Thank you both for sharing all of your knowledge during this webinar. It was great. I'm going to start the Q&A. It looks like our first question is, do virtual visits count towards meeting LUPA thresholds?
I'll answer that. And virtual visits do not count towards meeting your LUPA threshold. So it is important that you keep that in mind. With that being said, I don't discourage you from using virtual visits to help you meet your plan of care goals. I think there's definitely a place for them. It's just that you need to be mindful of how to utilize them. Keep in mind that a patient who's on service for wound care, for instance, wouldn't be appropriate for virtual visits. You can't provide wound care virtually. A patient who has just a pneumonia or a recent COPD exacerbation shouldn't have a large number of virtual visits because you can't listen to their lungs virtually. So there's going to be a balance of virtual visits that needs to be kept, but you can use them to help you meet your plan of care goals.
Great, thank you. And our next question is, how do we determine which discipline should start out at the higher frequency and taper down versus starting at a lower frequency and tapering up, as you mentioned?
Okay, I'll take that one. That's actually a really good question. How do we determine that? Say, for example, if we're starting care on a patient and they've sustained a fracture because of a fall, they may also have comorbidities such as CHF or diabetes, but those have been documented as well controlled. Probably in that case, well, definitely in that case, you would want to start off with a higher physical therapy frequency than a nursing frequency. And then as physical therapy finishes their work, they can taper down their visits while nursing can taper up to ensure that that patient is knowledgeable and has the necessary skills for self-maintenance of those chronic conditions such as CHF or diabetes. In this situation too, and piggybacking off of that last question, the virtual visits for nursing can be utilized while therapy is at a high rate of utilization. The nurse can check in with the patient and go over a few things while physical therapy is doing that inpatient, while that physical therapy is doing their high frequency. So we could intersperse those phone visits in there just to keep and make sure everything's going along as planned and that nothing's going on that the nurse needs to make an in-person visit. Carissa, any other thoughts on that?
No, I agree.
Okay. All right, and our next question is, if 2 visits are needed in a second period to prevent a LUPA, would they have to make 3 visits or is it actually 2 visits?
Good question, because it's confusing from PPS to PDGM, but the LUPA threshold, if the LUPA threshold is 2, then it's 2 visits that are needed to meet the threshold. So the threshold is 2, we need 2 visits. We are a full period if we have 2 visits. Okay, so it's the actual number. So if the threshold is 6 and we only have 5 visits, we are a LUPA.
Great, thank you. And our next question is, what is the best way to set up effective interdisciplinary collaboration?
Okay, great question. I'll take this one. Interdisciplinary communication is a condition of participation. We need to be talking with one another. If you don't have good interdisciplinary communication going on right now, the best thing is for senior management to decide on a formalized process when it's going to take place, who's going to be involved, what time points in care we're going to meet. Like, for example, the care team will get together at start of care. The care team will get together a little bit before the end of that first 30 days. And of course, we have to have collaboration. Have we met our goals? What are our barriers? Do we need to recertify this patient to meet their goals? Or are we at the point where we can effectively discharge that patient? Also think about other time points that maybe be a little bit more informal, like nursing going out and OT going out, and nursing finding out that OT is visiting on the next day, but the patient just said, I have a doctor follow-up. And maybe the nurse could let the OT know to reach out to the patient saying, okay, I had come to plan a visit for tomorrow, but the nurse is telling me that you have a doctor's appointment. Can we reschedule that for the next day? or something like the patient's in the hospital. And we see this a lot where someone finds out that the patient goes into the hospital and just tells one person, but not the entire team. So then other team members are contacting that patient and the family saying, can I come visit? And the patient's family is like, well, I told Nurse Nancy that mom went to the hospital yesterday. So that can impact a lot of things, because then all of a sudden it seems like we don't talk to each other. I know that was a big complaint that my parents had, that nobody seems to talk to one another. But if we are talking with people during those formalized processes and those informal communications, of course, they need to be secure, then it will look like we are talking with each other and communicating what's going on with the patient. Carissa, can you think of any other?
I just want to reiterate that we want to make sure that we're documenting that communication in the EMR. So if you're having like an interdisciplinary case conference, then you should have some sort of a form for documenting that. If it's an informal communication, then, whatever process you have, it's a coordination note or something like that, you should be including who you spoke with and what you spoke about in the clinical records so that it's very clear.
Okay.
Great. Just a reminder, you can type your questions into the Q&A box that's at the bottom of the Zoom webinar control panel. Our next question is, when spreading out visits for multidisciplinary cases, when do you recommend the evaluation visit be made by therapy, at the beginning of care or later?
I can take this question. So this is going to depend on the comprehensive assessment of the patient. So if we go out and do a comprehensive assessment on the patient and we determine that the patient really needs nursing at the highest frequency initially because they've just had a heart failure exacerbation, they're not well controlled yet, and they don't understand their medications, but they also do need therapy, we wouldn't necessarily want to delay the therapy evaluation, but we may not want the therapist to visit at the higher frequency initially. So we may want the therapist to visit at a little bit of a lower frequency initially as the nurse starts out higher and tapers down. As the nurse tapers down, that's when therapy could really bump up and really work with that patient because they're over that disease exacerbation hump. And so they're at a point where they're ready to work heavily with therapy. So we need to kind of think about it from that perspective, not necessarily delaying the evaluation, if that makes sense.
Great, thank you. Our next question is, do you have any recommendations for navigating patient care that often leads to an avoidable LUPA, i.e. one-time monthly catheter change?
I'll take that one. Keeping in touch with the patients on weeks that we're not scheduled to see them. Because remember, a lot of stuff can go on between catheter changes. People can go to the doctor. People can get prescribed new medication. Maybe they tripped and fell, and really we need to, offer them therapy. So making those weekly check-in calls when we're not scheduled to see the patient can really identify needs or things that are going on with the patient that need to be addressed with either a nursing visit or perhaps a therapy evaluation, or even something like, the patient changed caregivers or something changed in the caregiver's life where maybe we need to identify community resources. So maybe a social worker could come in and see if they can identify other things that could help out the patient through the community.
Yeah, absolutely. And, it's important to not get stuck in that sort of task-oriented mindset where you aren't viewing the patient holistically and you're only thinking, well, I'm only in here for a catheter change. You really need to think about what else does this patient have going on, because oftentimes the catheter patients have a lot of other things: congestive heart failure, diabetes, COPD. We need to remember those things as well and make sure that we're evaluating. And then also keep in mind, some LUPAs are still going to be unavoidable.
Right.
So it's okay. But best practice would be for those check-in calls between visits so that you can assess for any changes in status.
Great, thank you. Our next question is, what is your advice for to prevent LUPA when PTs are having many MD visits, and due to scheduling conflicts, there is difficulty in meeting?
Okay, so the patients are having multiple doctor's visits, and that's resulting in missed visits. And so what should we do about it is the question?
I believe so.
Okay. All right, thank you. Just want to make sure I'm understanding the question. So in this case, there are a couple things. One, a lot of clients that we have a calendar that's built into their folder that they leave in the patient's home, making sure that you are keeping that updated with the patient's doctor's appointments and with when they can expect your discipline visits to happen so that they don't forget. That's one thing. Two, virtual visits, right? Virtual care delivery. So if we know that the patient has radiation Monday through Friday, but they agree that they can do one visit during that week, let's make a second visit because we know they need a second visit. Let's make it virtually, so that we're not inconveniencing them by going to the house, but we're still touching base and we're still trying to work toward our plan of care. So virtual visits, we want to make sure that we're using those. If it's therapy, then that might be a little bit different. And I think then we need to evaluate, is this the appropriate frequency? Maybe the patient needs to have a lower frequency while they're undergoing radiation, and maybe they need nursing to do some virtual visits in between, and then therapy to bump up after their radiation is completed, because radiation doesn't last forever. So I think it's going to also depend on that, but virtual visits can be your friend in this situation.
Absolutely, and I believe they should be included on your plan of care if that's what you're planning to do for this patient. Those virtual visits really do need to be built into that plan of care that the physician signs.
All right, great. Thanks, Kathy and Carissa. Our next question is, do home health aid visits count toward the LUPA threshold?
Yes, they do. Good question, and they do. All your visits count with the exception of dietitian.
And there's still some questions on virtual visits and whether or not they count towards meeting your LUPA threshold.
They do
Unfortunately,
not.
They don't. Yeah, and they can't be. They don't count towards the LUPA threshold, and at this point in time, they cannot be billed to Medicare.
Right. But they can help you manage the plan of care and help you manage the patient. So there is value in them, but they do not count towards meeting your LUPA threshold. So as I had mentioned earlier, you really need to make sure that you're balancing appropriately with the necessary in-person visits.
All right. Any recommendations for patients who refuse their weekly visit on a Friday or at the end of the week?
Well, if they have weekly visits, if you're only scheduled to see that patient once a week, let's try to schedule them early in the week to move them if they refuse that visit on Monday, we can move them to Tuesday. So that would be my first recommendation. The second recommendation is if they're refusing their visit on Friday, then let's try to schedule them on a Saturday to make that visit up. Because as Carissa said, and as I emphasized, it's really important that we stick to the plan of care and make the visits that were ordered by the provider.
All right. And our last question, we run into the issue of patients requiring multiple visits and going well over the estimated revenue in the first 30 days. And then in the second 30 days, it may create a LUPA. How do we avoid going over the estimated amount without denying the patient needed services?
So it sounds to me like this is more of an issue of not thoughtfully planning out through the 60 days. So this is something that we're seeing a lot of, which is heavy utilization in the first 30 days. So we're seeing, nursing, PT, OT, home health aide, social work, everybody's in that first 30 days, and nobody, or maybe one visit or two visits into the next 30 days and discharge. We could definitely spread that care through the 60 days if we were a little more mindful and if we coordinated care a little bit better between the disciplines. So kind of going back to what Kathy was saying earlier about developing your plan of care. So the first 30 days, if it's a patient that just got out of the hospital, let's focus in on getting them over that acute hospitalization hump. So over the exacerbation that they had in the second 30 days, long-term disease management planning. The other things to remember, what is the most pressing issue going on with the patient at the beginning, whether it's start of care, resumption, restart, what's the most pressing issue for the patient? Is it their congestive heart failure exacerbation? Is it the fact that they fell and they have a vertebral fracture? Is it that they don't have any transportation assistance and they have to get out to dialysis 3 times a week? So what's the pressing issue for the patient at the beginning? And then let's use that to determine which discipline or maybe even disciplines need to be in at the highest frequency initially, and which ones could maybe start out at a lower frequency and then bump up as that initial discipline bumps down. So that initial discipline is in at the higher frequency and then tapers down in the first 30 days, and the next discipline is in but lower, and then they start to taper up into the next 30 days and then taper back down and out. We've got a 60-day period of care, and we've spread it well, and we're not overwhelming the patient. One of the things that we see most often right now are many visits all on the same day. I actually saw one a couple weeks ago, and the patient had 5 different disciplines on the same day. And they accepted them all, which is really highly unusual. Usually they refuse care. But I mean, if that were me, and think about it, if it were you, I would not have allowed all of those disciplines in my house on that one day. That's too much. It's very overwhelming, especially for somebody who just got out of a acute care facility or something like
that. All right. So if for some reason we did not get a chance to get to your question during the time of this webinar, we'll be doing another review of our Q&A deck, and we will be providing answers to each of you individually following the webinar. So thank you to everyone who joined us for today's webinar. As I mentioned earlier, stay tuned for an email with a copy of the presentation. If you have any additional questions or would like to connect directly with the McBee team to learn more about how we can help you thrive under PDGM, as well as leverage best practice episode management strategies to tackle the subsequent 30-day LUPAs, you can reach out directly using the contact information on this slide. or you can reach out on our website, mcbeassociates.com. So we look forward to connecting with you, and thank you again for your time. Have a wonderful rest of your day.
Thank you.
Thanks.